Everyone, welcome. We're going to be starting in about 3 minutes, so just hang tight. All right, I think we can go ahead and get started. Good evening, everyone. Thank you for joining us today for our program, Novel Therapies for Multiple Myeloma. My name is Lily Evangelista, and I am the Patient and Community Outreach Manager for the Leukemia and Lymphoma Society, Greater Los Angeles region. This program is a part of the Closer to a Cure community lecture series brought to you in partnership between UCLA Health and the Leukemia and Lymphoma Society. So before we get started on this program, I wanted to go over some housekeeping. So first, I wanted to make sure and highlight the chat feature at the bottom of your screen. If you have any questions for our speaker, go ahead and click on the chat icon, type in your question and send it over, and I will be reading them out loud during the Q&A at the end of the program. In the event that you have any technical questions or need assistance, we will also be able to communicate through the chat as well. We are recording the program today for your reference and to help others in the future. So to ensure we respect individual privacy, we will only be recording the presenters and their slides, and we'll have all other participants muted during the recording period of the program, okay? So very quickly, I also wanted to make sure that you are familiar with the Leukemia and Lymphoma Society. So we are a nonprofit organization focused on finding cures for blood cancer, but also providing support for patients, survivors, and family members navigating a blood cancer diagnosis. Our information specialists are master's level oncology social workers, nurses, and health educators who can be easily reached through our 800 number or online, and you'll see it on the screen here. So some of the things that they can help you access are personalized one-on-one navigational support, regarding disease and treatment information, but also looking into clinical trials, as well as nutrition consultations. They can also help you with educational materials that can be sent directly to your homes, as well as webinars and podcasts that are continuously updated. There's also peer support, and this can be connecting with someone one-on-one who has myeloma, for example, to get their unique perspective through our First Connection program or through support groups in the area that are happening online right now. But also we have online chats. So if you want to connect with others completely anonymously online, the myeloma chat happens every Monday evening. So you can go ahead and you can call the 800 number for that as well. Lastly, we do also have our financial assistance. So for example, we have our copay assistance program, which covers copayments and insurance premiums. And for myeloma, the coverage is up to $11,000. Okay, so also, if you are looking to get involved with the organization, we have numerous campaigns and volunteer opportunities available. So for example, in January, we have a campaign to ring in the new year. It's our Team in Training's Resolution Challenge. So if you're looking to get active or have health or wellness goals that you're aiming for, you can do it with a team and from a distance so that you stay safe. So this is a virtual challenge series, which allows you to choose your sport and your mileage goals. And it's completely free to join with no fundraising commitment. But if you want the opportunity to fundraise and support LLS's mission, we would absolutely welcome that. As for volunteering, you can always support other families or inspire others with your story. So please feel free to reach out to me after the program if you're interested. All right, so without further ado, I'd like to introduce our speaker from UCLA Health. Dr. Sarah Lawrence is here, or Larson, I'm sorry, Dr. Sarah Larson, and she can go ahead and take the floor.
All right. Okay, can you see my slides okay? Great. So thank you for joining us tonight, and thank you Leukemia and Lymphoma Society for all that you do in addition to setting this up in the partnership with UCLA. It's always exciting to talk about novel therapies in multiple myeloma, and I just want to give the objectives for tonight. So we'll start with disease background, because I know usually when groups come together, there are patients that are at different stages of their journey in multiple myeloma. So it's good to set a little bit of background to make sure that we're all on the same page when we start going through the exciting therapies. When talking about the novel therapies, tonight I'm going to break it down into two different categories. The first will be targeted therapies. So when we talk about targeted therapies, this means that it's hitting one of the lifelines for multiple myeloma. So it's not using the immune system as much, which we'll talk about later, but it'll use one of the methods that myeloma cells use to stay alive, and it'll cut off that pathway. So we'll first talk about selinexor. That is FDA approved and has the trade name Xpovio, but there are new combinations, and I will be able to share with you some of the data from the American Society of Hematology, the ASH annual meeting. It's this weekend that's coming up, but the information has already been made publicly available, so we can talk about it tonight. And then Venetoclax, which is FDA approved for other blood cancers, but not yet for multiple myeloma. Then the meat of what we'll talk about tonight is immunotherapy. So looking at the different ways that we harness the immune system in order to fight multiple myeloma. So multiple myeloma is the second most common blood cancer. It's the 15th most common cancer, and there were more than 30,000 new cases in 2018. Because patients with multiple myeloma are living longer, and we are very happy about the improvements that we've made recently, there are more and more patients with multiple myeloma living in the US. It's a little bit less than 2% of the cancer diagnoses, and the median age of diagnosis is 69. In order to talk about multiple myeloma, we have to talk about the immune system even before we talk about immune therapies. That's because when we talk about blood cancers, it's important to think about which of the blood cells becomes cancerous, because it helps us to understand the disease. In multiple myeloma, the blood cell that becomes cancerous is one of the B cells. So all of the blood cells start in the bone marrow, and anyone who's had a bone marrow biopsy does not need to know exactly where that is because it's shown right there on the diagram, but you know from your own experience. And inside the bone marrow is a factory where all the blood cells are made, and it interacts with the blood so that the blood cells start in the bone marrow and then move to the blood. So if you look at the other figure, you can see once they leave the bone marrow, then it can go through the lymphatic system, the spleen, the liver, all of the rest of the areas of the immune system. So looking at it in a little bit different way, the B cells start in the bone marrow. Then when they start to mature, they move into the blood, lymph nodes, all those organs we just looked at. Now, when B cells finish maturing, they become the cell called the plasma cell. And that's actually the specific B cell that becomes a cancer in myeloma. Now, again, this is part of the difficulty with that first diagnosis of myeloma, because most people don't know this. Because you talk to somebody who's maybe just newly diagnosed with lung cancer or newly diagnosed with breast cancer, and people know what those cancers mean. With multiple myeloma, it's hard because just telling them, oh, it's a cancer of a plasma cell, won't tell them as much as when you say, maybe I have colon cancer or lung cancer. What the plasma cell does is it just makes antibodies. So it goes back to the bone marrow and starts making antibodies. On the side of the slide there, you can see a little Y-shaped picture. That's usually how we depict antibodies. Now, antibodies have two parts, the Y shape, and that's what binds to its targets, and then the longer portion, which is what signals to the immune system, the other cells of the immune system, in order to target and then kill that myeloma cell. The antibody is actually what makes up the M protein. It stands for monoclonal protein. So the M protein is the tumor marker that myeloma patients follow. Most myeloma patients have both a heavy chain and a light chain. The heavy chains are given letters, so A, G, D, M, and E, and the light chains are called kappa and lambda. So many of you have gone through labs after a physician's visit and talked about the M protein, maybe talked about what that is. So it's an IgG kappa or an IgG lambda. The reason for that is that in the case of myeloma, the plasma cells stop making all the antibodies that your body needs, and they start just making the M protein, that one antibody that characterizes the multiple myeloma. Now, it's interesting because we also have taken the immunotherapies to understand more about targeting, but we also use actually the same structure. So when we use our antibodies in therapy, we actually synthetically produce the same structure that our bodies make in nature. And again, I think this is something that's being talked about more and more because the antibody therapies that are being looked at in COVID actually use the same structure, and again, have taken a lot from some of the blood cancers as far as the technology that they're using. So that M protein is a part of the spectrum of disease. So some of you may have had the diagnosis of MGUS first, which stands for monoclonal gammopathy of undetermined significance. The reason for that is that increased levels of proteins are actually probably more prevalent in the community than we know, but they usually don't progress to multiple myeloma, which is why we don't screen patients for it. And even with the diagnosis of MGUS, it's only monitored on an every 6 to 12 month basis. If there are more precursor cells there, then along that spectrum, it's smoldering multiple myeloma. Again, we, in most cases, don't treat smoldering myeloma and just watch patients. But what we'll focus on tonight is multiple myeloma, where there's actually a need for treatment. The indications to start treating, so if patients are being followed for MGUS or followed for smoldering myeloma, these are the criteria, they're called the CRAB criteria, that we look at as far as whether or not to initiate treatment. So if blood calcium levels are elevated, if there's any kidney dysfunction, the other name for kidney is renal, so that's why there's an R in CRAB, anemia, bone lesions, and then there was an addition of the biomarker to the diagnostic criteria about 5 years ago. So if there's an increase in the serum light chains, any abnormalities on imaging with CT, PET, or MRI, or if when a bone marrow biopsy is done, there's more than 60% of myeloma cells in the bone marrow, all of those would lead to a diagnosis of myeloma, which would indicate treatment. The pictures here, the one with the cells just shows what this looks like in the bone marrow. And then the X-ray shows the areas of lytic lesions. So I'll see if my cursor will show up, but the areas of thinning of the bone. So this is normal structure of bone and just this little area of thinning. So those plasma cells in the bone marrow interact with the bone and cause thinning. Those are the lytic lesions. So when we talk about bone involvement, it's not usually masses or tumors, it's actually thinning of the bone like what is shown here. So you see little punched out areas. The way we approach treatment for multiple myeloma is really like that of a chronic disease. We now keep patients on treatment, and we know that patients can do well for years with this approach. We call the first treatment, so the initial therapy, induction. The reason for that is that it induces a remission. Once patients are in remission, in most cases, an autologous stem cell transplant, meaning using the patient's own stem cells, is used. Then the patients go on to consolidation and maintenance, which each patient's physicians will choose for them based upon the patient's characteristics as well as the characteristics of their multiple myeloma. And then if myeloma comes back, at that point, the treatment of what we call relapsed disease. The arrow on the bottom is for the supportive care, because along with the actual myeloma-directed therapy, there's ongoing treatment to ensure bone strength, prevent against infection. So this is vaccines, antivirals, in some case antibiotics, or intravenous immunoglobulin, IVIG, as well as the ongoing support through each stage emotionally throughout treatment. Multiple myeloma is unique in a lot of ways, and it includes a response to treatment. So the IMWG is the International Myeloma Working Group, and they put together the response definitions. So when you see CR with an S before it, that is a stringent, complete response. And in myeloma, you can think about the word response interchangeable with remission. So again, we've chosen to use the word response in this disease, but really think about it like a remission. If there's no evidence of myeloma cells in the blood, urine, or bone marrow, that is a stringent, complete response. If there's no evidence, but there might be some by flow cytometry, which is one of the other methods that we can use to detect, so slightly more sensitive, then it's a complete response. If there's a 90% reduction in the marker used, so that could be the M protein or the kappa lambda light chains, that's a very good partial response, a VGPR. And if there's greater than a 50% reduction, but not yet a 90% reduction in that M protein or light chain, then it's a PR or a partial response. If these criteria are not met, then we refer to it as stable disease, SD. So this top line is what we're all working to change, that it's treatable but not curable. And I think that curable is within our near future, and I'll talk more about that at the end. When we look at the multiple myeloma disease course, again, think about each response as a remission. So patients will go through multiple lines of therapy and have multiple remissions in between. So we focus a lot on making sure that each of those remissions last as long as possible. We know that we have incredibly effective therapies for multiple myeloma now. So this chart shows the response rates to induction. OR stands for overall response, and the green bars represent the overall response. The yellow bars show the greater responses, meaning a 90% reduction or better. If you move to the far right side and look at RVD, which is the most frequently used induction regimen, you can see that the response rate in clinical trials was 100%. It's not very often that you see that, in particular in medicine. And the VGPR rate was greater than 70%. So we know we have this excellent efficacy in these induction regimens. But even when patients go into a complete response or a stringent complete response, the myeloma eventually comes back. The reason for that is there are myeloma cells that are present there, but they're below our limits of detection. So what we're looking at now in the field is, can we use a more sensitive method to detect these myeloma cells and continue to treat patients so they have what we're referring to now as a, quote, deeper response. And we're able to do that now because we have so many effective therapies. I like to use the iceberg analogy for minimal residual disease because right now with a lot of our treatments, we can get down to that CR, I apologize, I moved forward too fast, the CR or stringent CR level, but we know that there are still myeloma cells below that, but we just weren't able to see it before because we didn't have the methods to detect it. We have those now, and there is an FDA-approved MRD assay that's being looked at in clinical trials right now, which we may bring into standard practice probably within the next several years. And that will allow us to tailor each patient's treatment because like I already mentioned, we have multiple treatment options available for patients. So this list has around 15, is by no means exhaustive. This is certainly not a fully inclusive list of all the treatment options that are available. So not to go through each one of them, but to know that once patients have gone through that first induction, transplant, consolidation, maintenance, there are multiple treatment options available, and this is not even including clinical trials. So there's a lot out there that we can look at. But of course, we're still wanting to build on that, and that's what we're going to talk about tonight. So some of the targeted therapies. So I talked a little bit about selinexor. Xpovio is its trade name. And this is really interesting because of how this medication works. So there's usually a protein called a tumor suppressor protein, TSP. Now, when this is present inside the nucleus, the smaller portion of the cell, that cell will not keep growing and dividing. The whole goal with all of our therapies is to prevent the cells from growing and dividing. So if we can do that, then we can kill our tumor cells. So what will usually happen is that these tumor suppressor proteins in the nucleus bind XPO1, so that's why it's called Xpovio. And then XPO1 takes the tumor suppressors out of the nucleus, where then all of the mRNA can be made into proteins and these cells can continue to live. So if we can block these XPO1 proteins, all the tumor suppressor proteins stay here in the nucleus, and then the myeloma cells die. So it's really a novel mechanism of how this works, which is why it's been exciting. In the STORM trial, which led to its approval, the response rates were in the 20 to 30% range and about a 5-month duration of response. So of course, we're wanting to improve on that. And this is some of the data that's being presented this upcoming weekend at ASH. So there are 2 combinations with very favorable results that are being presented. The trial is called the STOMP trial, and one of the arms has the drug selinexor, carfilzomib, which you may know as Kyprolis, and then dexamethasone, which many of you just know as a very interesting medication for many people to take. For patients who had had 3 prior lines of therapy, 75% of patients responded on this trial and tolerated it well, which is of course a very exciting response rate. It was a little bit lower if patients had had a therapy called daratumumab or Darzalex, but still, again, a very favorable response rate. They also looked at this medication in combination with pomalidomide, also known as Pomalyst for the trade name. Again, patients who had had 3 prior lines of therapy with a very nice response and much more durable than what was seen with just selinexor and dexamethasone alone. The other medication that I mentioned is Venetoclax. What Venetoclax does is bind to this protein called BCL2. And what that does is allow the other proteins that are important in the cell death pathway to attack the myeloma cells and kill them. In multiple myeloma, we will sometimes describe the myeloma cells by some of the changes in their genetics. So it's important to note that this is not genetics as far as inherited. So it's not something that the patient's inherited. It's not something that the patient's passed down. It's something specific to the myeloma cells. One of the translocations that occurs in about 15 to 20% of patients is the 1114, which is shown there on the second line. In patients who have that, Venetoclax can be a very effective drug. And currently there are ongoing clinical trials to look at this also in combination therapy, since we usually will do combination therapies in multiple myeloma. These were not reported at ASH, so we anticipate some of the other reports at later meetings. So then moving into immunotherapy. So again, going back to this base that we've looked at, where this is the structure that we use for the antibody, which can bind to any target on the surface of the myeloma cell. And then the other side signals to cells of the immune system to attack and kill the myeloma cell. And so when we talk about targets for multiple myeloma, there are several targets available on myeloma cells to use. But whenever we're looking at this, we have to be very careful to make sure that the targets on the myeloma cells are only on myeloma cells and not on normal cells, because otherwise we could redirect the immune system to kill healthy cells. Some of the targets we've already mentioned. So the target here has daratumumab, which is Darzalex, a very commonly used antibody, and CS1, which is elotuzumab, which is another very commonly used. Now, when we're looking at other modalities that build on just a basic antibody, we're looking for something that's more specific to the myeloma cells, meaning that it's only on the myeloma cells and not on any healthy tissues that could cause there to be more side effects when we use the therapy. And that's why a lot of these hit something on myeloma cells called B cell maturation antigen, so BCMA. One of the things that we can do with engineering of T cells and antibodies is that what I already showed you is that there's the antibody that binds to the myeloma cell, but you need to have the immune cells in close contact. So what we can do is also make an antibody that binds to the T cells, one of the cells of the immune system that's important for the killing aspect of the immune therapy. So what's shown here is that there's what we call a BiTE, so a bispecific antibody that will bind both the myeloma cell as well as a T cell to bring them in that close proximity so that the myeloma cells are more likely to be killed by the T cells. So these are in ongoing trials right now, again, targeting BCMA as well as the T cell to bring them closer together and provide more efficacy for patients than if we were to use the BCMA antibody by itself. Right now, these are in phase 1, so they are very early in development, but the overall response rates look really favorable, so around 70%. It also looks like the side effect profile is very favorable, so very exciting as we continue to look at these trials, but again, not close to FDA approval at this time. The recent approval that targets BCMA is a drug called belantamab mafodotin. Its trade name is BLEN Rep. What this does is connect chemotherapy to the antibody so that, as shown in the picture, that antibody that's carrying the chemotherapy, which is labeled there as a toxic payload, binds to BCMA. When that binding happens, the myeloma cell brings both the antibody as well as the chemotherapy into the cell, which then causes breaking apart the chemotherapy and the antibody and releasing that chemotherapy or toxic payload into the cell, resulting in death of the myeloma cell. So it's a targeted delivery of chemotherapy, but also can signal to the T cells to kill it. So it really has a dual mechanism. This was recently FDA approved for patients who had had 4 prior lines of therapy and based upon a trial called the DREAM trial. The response rate is about in the 30% range, which again, we see that, and that's good for this many prior lines of therapy, but we know we can make that better by going into combinations. So that's what we're starting to look at now. The availability of this, I think, is going to be variable because there is a side effect that involves the eye. So because of that, patients need to be seen by an ophthalmologist that's trained in this prior to the first dose and then before every subsequent dose. So thankfully, we have a very strong ophthalmology program with the Jules Stein Institute, but of course, you'll need to make sure that your provider has connected with an ophthalmologist that is trained to administer this because it is a requirement for patients. So one of the hottest topics in myeloma right now and across blood cancers are chimeric antigen receptors, or CAR T cells. So the reason for this is because CAR T cells bring together the recognition from the B cell and connect it to the killing machinery of a T cell. So what you can see here, and I'll try not to keep advancing the slide with my cursor, and I apologize that I keep doing that. So this is the area where a B cell can say, this is what needs to be targeted by the immune system. And then the T cell is the cell that has the appropriate machinery to kill the cell. So if we bring together both of those pieces, which is shown here, so outside of the cell, we'll find the myeloma cell, and then we'll signal inside the cell to directly kill. So you get around what we've talked about with the bispecific, where you're trying to bring the T cell in, because it's all packaged right into the patient's own T cells that are going to express this CAR. So to look at it in another way, you have the T cell. So the patient's T cells have been taken and engineered to have this on them. So when we put the T cells back in, they are able to go find the myeloma cells and then kill them on contact. What it looks like for a patient is that we first have to collect the T cells. So we do that in hemopheresis. So for patients who have had a stem cell transplant, it is a similar procedure where you go onto the hemopheresis machine for about 3 hours, and that is sufficient to collect the T cells. The T cells then need to be manufactured, and that takes about 3 to 4 weeks. During that time, patients go home and they may receive therapy during that time. If they do, we refer to that as bridging therapy. It's just to make sure that the myeloma is still controlled during that period of waiting. Patients receive chemotherapy as an outpatient before they come into the hospital to receive the T cells. The reason for that is that we don't want the patient's immune system to have any impact on our engineered T cells. So we do have to remove some of the patient's own immune cells before we give them back the engineered T cells. For most of the clinical trials, as well as the FDA-approved products that are available for lymphoma, patients are admitted to the hospital. But because we are seeing very favorable safety profiles, that is something that may change in the near future. When we talk about side effects, there are 2 main side effects to CAR T cells. The first is something called cytokine release syndrome. So these T cells are very good at their job. So when they go to kill the myeloma cells, and they do it very effectively, they release these chemical signals that we call cytokines. So cytokines increase the immune system and cause a lot of inflammation. That inflammation can lead to low blood pressure, requirements to be on a ventilator or a breathing machine in very severe cases. The majority of patients do not have severe cases, and they have more mild, which can just be a fever, but it's one of the main side effects that we look for. The other thing that can happen is neurological toxicity, which we refer to as ICANS. That can happen either with or without the increasing inflammation and is fully reversible once the patient is appropriately treated for it. There are some other things that can happen, including long-term low blood counts, maybe not getting back up to the normal range. Again, not that they're requiring transfusions, but the blood counts are just lower than the normal range. And there is an increased risk for infection during this time because there was the chemotherapy given and potential for some low blood counts. The timeline of how this happens, so patients receive 3 days of what we call lymphodepletion chemotherapy. Day 0, so for, again, patients who've had a stem cell transplant, we use very similar nomenclature. And then the time that there's most likely to be any cytokine release syndrome, CRS, or neurotoxicity is generally most frequently within the first 7 days, sometimes up to day 14, and then very rarely there's a delayed onset neurotoxicity, but usually if there are going to be side effects, it's within the first 1 to 2 weeks. One of the first CAR T cells that will soon be FDA approved, looking for its FDA approval probably sometime in this spring, so spring of 2021, is Iacel. It was previously known in clinical trials as Bluebird Bio 2121. In the first trial, there were 33 patients treated. These patients had had 7 prior lines of therapy, so more than double what I was talking about for the other trials. And they looked at different cell doses to be given to patients. So it's important to see that with this 85% response rate, that's not even with all patients getting the highest potential cell dose. I also already mentioned minimal residual disease, or MRD, and many of these patients who responded were MRD negative, so meaning the deepest response that we can see with myeloma, and a longer duration of response. And again, this is just as a single infusion without having to be on any therapy once they leave the hospital. When we talk about side effects, so both CRS and ICANS, we talk about grades. Low grades, so grade 1 or 2, usually require minimal intervention, where grades 3 and 4 require more intense intervention. And you can see that very few patients on this trial required a more intense intervention for their side effects related to CAR T. Because of how effective this was, we currently have ongoing a trial called the KarMMa-3 trial. What this does is take patients and it randomizes them in a 2-to-1 fashion. So for every 2 patients that go on to the CAR T cell therapy, 1 patient goes on to standard therapy. The standard therapy options that are available are listed there. That's not all of them. There are up to 5 that could be chosen, but just to use as examples. This is for patients who have had 2 to 4 prior lines of therapy. And again, we're currently enrolling. So because of how effective we've seen CAR T cells in patients who have had 7+ prior lines of therapy, we're now looking to see, can we bring it earlier in therapy and have even more impressive results for patients? Which is why the trial that we will soon have open as well is the KarMMa-4. So KarMMa-3 is enrolling. KarMMa-4 is just about to open with us at UCLA, and it's open at other select sites throughout the country. But for patients who have what we would refer to as high-risk multiple myeloma, so there are the genetic abnormalities that I mentioned at the beginning that can make a patient high risk, or having an elevated LDH. If that's the case, a patient could go on this trial where instead of going on to an autologous stem cell transplant and auto transplant, after they've responded to induction, they would go on to CAR T cell therapy. After CAR T cell therapy, they would go on to maintenance just like they would after an auto. Their stem cells would also be collected to make sure that that would remain an option for them. The other CAR T cell called Orva-cel, its name in the trials is JCAR H125. This is interesting because they take the patient's cells, and there are different types of T cells. And in this one, they actually do a mix of CD4 to CD8. A lot of the other CAR T cells will just take all the CAR T cells available, or all the T cells available to modify. This one's looking at to see whether or not a ratio can actually improve how effective the CAR T cell is, and see if some of the toxicity can be decreased as well. This trial is still ongoing, but 62 patients have been reported, and the overall response rate is 92%. So we're getting to really high levels of response for patients who have had multiple prior therapies. Very little high grade, so the more severe requiring more intervention of either CRS or ICANS, the 2 main side effects. So again, looking like a very favorable safety profile. Just to look at the clinical trial summary, so all of these are CAR T cell trials that have looked at targeting BCMA in myeloma. So the early ones were at the National Cancer Institute, University of Pennsylvania. I mentioned the KarMMa-3, which is with Iacel. There is another that's the Cartitude, which is now owned by Janssen, and then Evolve, which is the Orva-cel trial. These are heavily pretreated patients with anywhere from 5 to 9 prior lines of therapy, and response rates that are in really the 85 to 100% range, and these are in really heavily pretreated patients. The Penn trial is interesting because theirs are a little bit lower because they did a different chemotherapy beforehand that we would not use now, and the cell dose was a little bit lower. So more of a pilot, and that's why the responses were a little bit lower. But otherwise, across the board, we're seeing 80+ response rates in patients who have had multiple prior lines of therapy. So just to go back over a summary, because I know this is so much information all at once. So when we look at the monoclonal antibody, again, same structure of what our bodies make, it's just that we synthetically engineer it. When we build on that, we can have what's called the antibody drug conjugate. This is what belantamab mafodotin, or BLEN Rep, is, where it is the antibody with a payload or chemotherapy attached to it, which is depicted by the star. There's the bispecific antibodies, which bring together both the T cell as well as the myeloma cell. And then there's the CAR T cells, where we take patients' cells, we engineer them so that they have the protein that recognizes the myeloma cells on the outside of it, and the inside of it has the killing machinery so that it does not require the patient's immune system. You've taken that out of the equation. When we look at these therapies, there's the potency as well as the potential for toxicity. So we are continuing to work on our CAR T cell engineering, but of course that can be a limiting factor. They are very, very effective, but many of the products have the potential for more toxicity, more side effects than a monoclonal antibody. So this is a figure that's from a recent review that I thought was really interesting to look at. And I think part of that is because first, it's just so encouraging because it's the whole field talking about a cure, which I'll show in the last column. But there was concern about whether or not things would still get approved and with COVID. And so I think my first criticism of this is that I would use a bigger monster for COVID, because that seems like kind of a small animal for the bigger monster that it is. But when we look at that, imminent and near future, the approval of subcutaneous, so the injection of daratumumab has happened. Isatuximab, the other name for that is Sarclisa, has been approved. There's approval of the BCMA ADC, which is BLEN Rep, or belantamab mafodotin. And although we haven't had it yet, the approval for the BCMA CAR T cells are coming, and we anticipate that coming this spring. In about 1 to 3 years, we will probably have earlier immunotherapy lines of therapy for patients, and I showed you that in some of the clinical trials that are ongoing. We will also likely have approval for the bispecific antibodies, because those have continued to show improvements in their outcomes. And if those trials continue the way the phase 1s have, that will likely be another option. Finally, in greater than 3 years, I think this is really the thing to look at now, is that second from the bottom, can we cure myeloma with immunotherapy? And it's good to know we're in that range where we're getting closer and closer with all of the options that we have to treat patients, and the more sophisticated we're becoming with our immunotherapies, that having chemotherapy-free approaches of cure are really within the horizon for myeloma patients. So of course, we're always working to improve these outcomes, as I mentioned. And one of the things that's being worked on here at UCLA in the lab of Yvonne Chen is, can we design a better CAR T cell? One of the ways that myeloma can get around the BCMA CAR T cells is by getting rid of BCMA. The myeloma cells can be smart. So if we target both BCMA and CS1, we could prevent one of the ways that myeloma can relapse after CAR T cells. And so depicted here is what is being made in Dr. Chen's lab, where we can target 2 different areas, and binding either CS1 or BCMA would lead to activation of the CAR T cell and myeloma cell death. So the California Institute of Regenerative Medicine has given us the grant, and we're currently working on the studies to hopefully be able to bring this to a clinical trial. Just to give you an idea about some of the multiple myeloma trials that are present at UCLA, and all of these are present on clinicaltrials.gov. And again, thank you always to Leukemia and Lymphoma Society for helping patients to find clinical trials for which they may qualify. And then my last thank you, and again, I'm glad that we started with looking at the resolution, since I know a lot of us are missing some of the other team and training events. Nearest and dearest to my heart is Climb to Cure. You can see us there on the top of Mount Kilimanjaro on the inaugural hike, which I did with one of my very incredible and inspiring patients. So again, thank you for all that you do, and we can stop there for questions. Thank you.
Thank you so much, Dr. Larson, for sharing your time and expertise on this topic. If you can unshare your screen, and then that way we'll be able to see you as we're answering the questions. See, so we're going to go ahead and get started on our Q&A. And if you have any questions or you haven't already done so, please go ahead and put them in the chat, and Dr. Larson will be able to answer the questions. So for the first question that we have, so what multiple myeloma drug has the least serious side effects?
That is a hard question to answer, because all patients respond differently to medications. And so I wish we had a way to predict for each patient what their toxicity would be. And so we know what the profiles are for each of these medications, and we can look at any other medical problems the patient may have or pre-existing symptoms. And we need to use that to guide us, but there's not one therapy that overall we could say is the safest.
That definitely makes sense. The second question I have, so how long can I expect maintenance therapy with Revlimid to last after induction?
So in the setting of a stem cell transplant, we would expect to be able to be on Revlimid maintenance for around 5 to 6 years.
We have a question in the chat. For the active karma trials, do you anticipate that remission duration times will increase as you enroll patients that have had fewer prior treatments?
The thought is that in patients who have had fewer lines of therapy, the T cells that we collect to modify to make the CAR T cells will be a more favorable group of T cells because there's been less therapies given to that patient, which means that the T cells could be more effective and they would also last longer. So yes, the thought is that using the CAR T cells in earlier lines of therapy would increase how well patients respond and for how long they respond.
Gotcha. Okay. What are the side effects of CAR T cell, CAR T cell therapy, and what is the average remission time?
So
I think
the
you talked a little bit about it.
Yeah, so the two major side effects are cytokine release syndrome, which is the overall inflammatory response that can happen when T cells become activated. And it can lead to, in its mild form, fever, in its more severe form, low blood pressure, and fluid within the lungs that can require ventilation. So that happens very rarely. That's what I showed from the trials. It's only on the order of 2 to 6%, so very few, but it is a potential, and obviously we always have to talk about those side effects when we counsel patients. As far as the remission duration, it looks like it's probably around 1 year, but we'll have to see what that looks like, again, because we will likely be using this therapy in patients who have had fewer lines of prior therapies. In these clinical trials, patients have had 7, 8, 9 previous therapies. And with the FDA label, I think it would be unusual for us to be treating with that many lines of therapy before going to CAR T cells.
Gotcha. Okay. The next question I have, I am a multiple myeloma patient with kidney involvement. I'm on dialysis. Which of the new treatments would be appropriate for people with kidney issues?
So thankfully, a lot of the medications for multiple myeloma are appropriate for patients whose kidney function is not in the normal range. So a lot of the immune therapies are fine for patients who are on dialysis. CAR T cells have not been studied in patients that are on dialysis, so that is an area that will need to be evaluated.
We do have a question, and I don't know if this was in the slides, but what do myeloma cells look like?
So they were in the slide. It was in the slide that had the picture of the skull with the lytic lesions and then the picture of the bone marrow. So they are round and their nucleus, which is the circle within the circle, is off to the side. So that's what they look like.
Gotcha. Well, will they be able to have access to the slides after this program?
Yes, that's fine.
Yes. Okay, we can send it over so that people can get a better picture of the myeloma cells. What is available for relapse patient that might be non-secretary? VRD, ASCT, RD, maintenance 8 years.
So with patients that are non-secretory, they still have the same options available. The only limitation is enrollment on clinical trials, because many clinical trials don't include non-secretory patients because they need to follow their disease markers every month. And that would mean that a patient would need to have a bone marrow biopsy every month. And since most people aren't signing up for that, most trials don't include patients who are non-secretory, but all the other options would apply.
Gotcha. Okay. Do you see CAR T cell therapy replacing the traditional stem cell transplant one day?
I think it's possible. We have to do the comparisons, we have to do the trials. We're also just in the beginning phases of looking at CAR T cells. So we're excited about these responses, but we certainly know that there's substantial optimization that can be done to these CAR T cells. And that's one of the things that we're working on. And again, Dr. Yvonne Chen is a brilliant bioengineer looking to see ways, how do we make these CAR T cells more effective, safer, and more persistent.
Yeah, yeah. It's a lot of exciting research that's going on, and so
yeah.
lots to hope for. The next question we have, do you have any thoughts about stem cell transplants with consideration given to the increases of coronavirus infections?
So that is obviously an ongoing topic. When we first were making adjustments because of coronavirus in the spring, the International Myeloma Working Group and some of the major centers here in the US closed transplant programs, ours included, for a period of time. We have since reopened, and with the appropriate screening and the appropriate capacity within the hospital, most transplant programs are staying open right now. Of course, with everything related to COVID, it's a dynamic situation. I don't see us needing to close our transplants again at this point. But of course, we're always looking at the safety of patients to look at the risk-benefit ratio to see which favors, you know, holding versus continuing with the transplant.
Gotcha. Okay. So that's all the questions that I had, both from the chat and registration. Is there any other questions that's out there for folks that want to type it in really quick? Kind of give it a moment. Not seeing anything, so I think that is it. Okay, yes, I think that's everything.
Okay.
So with that, at this time, I think we're going to be closing up on behalf of the of UCLA Health and Leukemia Lymphoma Society. Thank you all so much for joining, and have a great evening.
Thank you.